So, Sumit, hello. Sumit, please unmute your.
Yeah.
So, Sumit, like, when
Yeah,
you'll
yeah.
be going to go live, you
I'll
just
start.
on a count of 10, you can tell us, and when we are live, you can just tell we are good to go. Then Ashish can start with the introduction.
I think we are live now.
Yes.
A very good evening to everyone present for the workshop and a hearty thank you for joining us. I feel proud to announce Global Association of Indian Medical Students on the occasion of World Restart a Heart Day is conducting a hands-only a CPR training workshop. The golden technique, which we all know as CPR, Cardiopulmonary Resuscitation, is an emergency life-saving procedure performed when the heart stops beating. We will have a training session of 40 minutes. All doubts can be addressed in the chat box. The questions will be collected and addressed and answered at the end of the training session. We are honored to announce that we have with us the supremely talented and respected Dr. Rakesh Garg sir. Dr. Rakesh Garg sir is an anesthesiologist, intensivist, pain and palliative medicine physician. He has done the fellowship in palliative medicine from Institute of Palliative Medicine. He is the associate professor at Department of Onco-Anesthesiology, Intensive Care, Pain and Palliative Medicine at AIMS, New Delhi. He has over 260 national and international publications and authored more than 20 chapters in books. He has delivered over 100 guest lectures and panel discussions at various national and international conferences, CMEs, and workshops. He has also conducted over 50 workshops in this field. He is presently serving as editorial board members, reviewer for various national and international journals. He is also the founder director of Global Association of Indian Medical Students and director of academics of Indian Resuscitation Council. We're very honored to have you with us, sir. Over to you.
Thank you so much. I bring greetings to the Global Association of Indian Medical Students. I think it is really a privilege to speak among this association, in which I can see a lot of enthusiastic people who are taking a good lead into various aspects of the medical education. I think I can see so many bright students who are working so enthusiastically over the last couple of weeks. And I'm sure and I wish the GAIMS are very fruitful endeavor in the future, so that they have a community wherein they can contribute towards the various aspects of the growth of just not the medical students, but the overall medical education in a big platform. And thanks to Shubham and Ashish and all the team members for giving this kind of opportunity to me to interact with you. So as I have been instructed, I will speak for around 30 to 40 minutes, and I'll be open to the questions, whatever you have. So absolutely, I think no time constraints thereafter. If you have any queries, any questions, most welcome. So when we say the cardiopulmonary resuscitation, this is one of the important event which is required for resuscitating a patient outside the hospital. And the reason is that why do we need CPR? The reason is very clear. Now, whenever the cardiac arrest happens, the perfusion of the vital organs starts diminishing. And then once complete cardiac arrest happens, there is no perfusion. The oxygen reserves which are present inside the body, they have a limitation. So after some time, the oxygen reserves gets depleting across all the cells, and then start the hypoxic injury. And if this hypoxic injury manifests, then obviously the recovery of various vital organs, specifically the heart, the brain, the kidney, they become failure. And even if you do something after that, the outcome is not good. So this means that during this time frame, this means within say 1 to 2 minutes, or maybe not more than 5 minutes, somebody has to provide resuscitation to these patients, so that the hypoxic event should not start at the tissue levels. Now, if you see the Indian scenario, and this is just not Indian scenario, but it is also in many of the developing countries, that the education about or the awareness about the CPR is not much. Only a percent of patients or lay persons are aware of how to do cardiopulmonary resuscitation. So that's why it becomes important to understand that performing CPR at the right time in a right technique is very, very important. And CPR can happen at any time. I mean, most of the time, if you see the literature, almost 80% of cardiac arrest will be happening outside the hospital. So that's why everybody, the most important, the bystander, should be aware of learning CPR so that they can provide services when the cardiac arrest happens. They can happen at any moment of time. The emergency department will bring the patient to the emergency department. And then we have various type of hospitals, starting from the basic to the advanced one, wherein you can provide all services. So there is a huge infrastructural gap across hospitals wherein you provide these services. So due to this, considering this aspect, the Indian Resuscitation Council has developed certain guidelines which are required. Now, the compression on the life support is a guideline for doing CPR by the layperson or the bystander CPR, what we say it otherwise. The basic cardiopulmonary life support, which is for trained medics and paramedics outside the hospital, and the comprehensive cardiopulmonary life support, which is for trained medics inside the hospital. Now, GAIMS is a big organization, and it has so many medical students associated with it. So I would like to discuss all these guidelines subsequently, but today I would like to have more emphasis on the first guideline, that is the compression on the life support. We have certain links, and these are the algorithms which we'll be discussing step by step in subsequent webinars. But today I will be highlighting this yellow colored algorithm, which is compression on the life support. Now, when we say cardiopulmonary resuscitation, these guidelines has been published in the Indian Journal of Anesthesia, which is a peer-reviewed journal. So you can go through this journal for further details. Now let me start with this event. Now, if you observe a person who suddenly collapses in front of you, or if you see a patient, a victim, who is already collapsed when you saw him for the first time, what you need to do? Now, we need to remember these three important links. Now, these are the three important aspects which we need to remember for resuscitating a patient. And these are called code links. And this is specifically for adults. We'll not be discussing much about pediatric age group today because they have some different concerns. So we'll not be going into those details today. The first aspect, the most important, is the recognition. And it's just not the recognition of a cardiac arrest, but it is also important to understand that the recognition should be done at the earliest. As I mentioned earlier, the chances of return of spontaneous circulation or the revival of a patient decreases by almost 1%, by 7 to 8%, if the resuscitation is not starting within a minute. And if you start at 10 minutes, after 10 minutes, the resuscitation, the oxygen levels are so low, the chances of hypoxic injuries are much higher, and the outcome of patient is not good. So we need to early recognize these patients, and simultaneously, because the cardiac arrest has happened outside the hospital, we have to shift these patients to the nearest medical center. And that's why we need to activate some of the emergency transfer services like ambulance, which can transfer this patient to the nearest hospital. The second aspect is when we have recognized, when we have activated the medical services, we need to start the resuscitation. Now, the basic key aspect, if you see for the adult resuscitation, the most common reason, almost more than 85% of patients, will be the cardiac cause. And it will be taken care if you can provide the chest compression so that whatever the insult has happened at that moment of time, you can reverse it by manual chest compression. But again, it needs to be started at the earliest. So early chest compression is very, very important. And patient needs to be shifted to a higher center because we need to add on extra things to it. Like, for example, the ventilatory aspect, the drugs, and looking for the underlying etiology for which the patient has gotten cardiac arrest. So that's why these patients need to be shifted at the earliest so that these advanced interventions can be done for these patients at the earliest. So these are the three important links that should be remembered when we are resuscitating a patient outside the hospital setting. Now, this is the algorithm that we need to remember, a simple algorithm, not more than 4 to 5 steps that needs to be done. And if you do it, the chances of patient's revival maybe increase a couple of times. So let's see one by one what needs to be done for a patient with cardiac arrest outside the hospital for bystander CPR, or what we call as compression-only life support. Now, the first step when we say outside the hospital, you need to ensure the safe place. Now, sometimes if you see, there will be a couple of places which may not be quite safe. And you need to remember that starting CPR in these situations may harm the bystander. For example, if a house is on fire, or somebody is on the middle of the road, or somebody is inside the car which is on fire, or somebody has electric connections and is near the electrical wire. So if somebody starts the CPR in these situations, then the chances of harming that bystander will also be more. So what needs to be done is you need to look around the scene to ensure that there is no imminent danger or threat. If you find that there is some danger for it, you need not to start the CPR, but you need to call the concerned persons who can help you for shifting the patient from an unsafe place to a safe place. For example, if the patient is on mid of the road, the police personnel can help you to cordon off the space or can shift the patient to one side. If the car is on fire or the house is on fire, the fire brigade people who are expert in managing these patients by bringing them out to a safe environment can be done. Patient is near the electrical wire, the electrician should switch off and somebody should safely move the victim to a safe place. So this means once you have ensured the safe place by calling the person who can shift that victim to a safe place, then you can start the CPR. Now, these patients can be shifted away by the experts. So don't try to fiddle with the patient unless you have your safety guards with you. Now, once the patient has been shifted to the safe place, the next important response would be to check response. Because at times it can happen that patient may have momentarily loss of consciousness, which could be vasovagal, or maybe because of just tiredness, or maybe the patient is resting otherwise, and you saw that the patient is lying, but he may be resting for some reason. So for checking the response, what you need to do is you come from the front. Now, this is an important point. You come from the front and tap on both the shoulders with both of your hands and ask loudly. Now, never try to come from the back of a patient, because if patient has a history of fall, there could be a chance of cervical spine injury, and that can lead to some concerns, because if patient moves the neck, there could be an exacerbation of the cervical spine fracture, and that can exacerbate the patient's symptoms. So always come from the front, introduce yourself, tap on the shoulder, and ask loudly in whatever language patient can understand. Hello, are you all right? What happened to you? I'm Rakesh. I will be helping you. So you can just start talking one or two things so that you can elicit the response. Now, if a patient shows some verbal response or a purposeful movement and is breathing normally, then it's okay, then fine. This means patient may have transient loss of consciousness. You need to just monitor the patient and you can shift him to the nearest center so that the healthcare personnel can take care of for further examination. But in case patient is unresponsive, then what you need to do is you need to call for help. Now, which I mentioned in the first link, recognition and activation. Recognition you have already done with checking response, and activation you will be doing now. So the third step, the first step being the ensurety of safe place. The second step means checking the response. And in case patient non-responsive, you activate the emergency medical services. Herein you can shout for help, or the bystander whosoever is present there, you can ask him to call somebody, call the ambulance. Or if there is nobody around you, you can take out your mobile and call the emergency number. Different states of India have different emergency number. For example, in Delhi, it is 102 and 1099. 108 is going to be probably a national emergency number. So you should be aware of the emergency number of your state and you need to call them. Whenever you call for the medical services, it is very, very important to give them certain important information. Sometimes we are in so much of hurry, we are panicked. We just call and say that some complication has happened, some victim has cardiac arrest, some victim has collapsed, come fast and attend him. And then we disconnect the phone. So in this way, we are not able to give the relevant information. So whenever you call the emergency medical services, always remember that these information should be given to these personnels. Identify yourself, identify your exact location. Though we can locate by GPRS system, but it may not be feasible for many of the ambulances. The system may not be available there. So you identify your exact location where you are so that the ambulance can come direct to you without wasting time for searching you. Tell about the victim's condition. Maybe it's a trauma scenario. There could be more than one victim. So that's why the ambulance services may be required more than one. So obviously, always when you call, you just emphasize on the number of victims, approximate age, and their overall general condition, whether they have just trauma or some injury, or they have cardiac arrest. So you need to specify those things so that appropriate help can be summoned through those ambulances. And also, you can always, when you identify yourself, you can say how many number of rescuers you are there, so that they are aware that they will be getting some helping hand. And you can always emphasize that whether you have got some training for providing CPR or not. Always remember, there could be some network issues. They may not be able to hear everything. There may be some disconnections in between. So whenever you're calling, until unless the other side says, yes, we have heard, we are sending the ambulance, do not switch off the phone. Just hang on only when asked to do so by the emergency medical services. Now, once you have activated the emergency services, you need to start the chest compression. Now, chest compression is the key, as I mentioned earlier, because majority of time, these patients would be having cardiac issues. So you have to sustain the cardiac compression by providing them manual chest compression. Now, when we say chest compression, it should be a sequence of chest compression. We can say 30 compressions 5 times. So it will be approximately non-stop 150 chest compressions. So this is what needs to be done. And whenever these compressions are being done, you need to take note of the time for them, right? The first step for providing chest compression is you need to identify where you have to provide this chest compression. So the position and placement of hands needs to be identified. So what can be done? Suppose this is the patient here. So you need to identify the xiphoid process. Now, xiphoid process is the lowest end of your sternum. So everybody of you must have learned in anatomy the sternum. You can palpate yourself, and when you go there, just below it, whenever your sternum ends, you identify that xiphoid process. At that point, you keep your 2 fingers like this and keep the heel of the other hand, as shown in this picture, over the 2 fingers. So you should keep 2 fingers and then the heel of the hand, and then keep the other hand over the first one and interlock your fingers. Now, this position is very, very important because until unless you identify this position and start giving chest compression at this point, if this position is not correct, then the chances of optimal chest compressions may not be there. Patient may not have a cardiac output. So that's why identification of this site is very, very important. So I repeat it again. Suppose a patient is lying outside, you just identify the lowest end of the xiphoid process. Keep your 2 fingers above the xiphoid process. Keep the heel of the other hand over the sternum and the other hand over the first one and interlock your fingers. The finger should not be touching the chest, as you can see here. Now, this should be your position now. Once you have identified, you need to lean forward so that your shoulder, your elbows, and your wrist, they're in the straight line. Now, this position is very, very important. You need to kneel beside so that you are taking this position, and the whole force for the chest compression is coming from the shoulders, not from the wrist or the hands. Now, once you have taken this position, you need to start the chest compression. Now, how much to compress? Usually, it will be 5 to 6 centimeter. So you should press at least 5 centimeter, but not more than 6 centimeter. Now, how should be the speed of the chest compression? It should be 120 times per minute. So this means there will be 2 compressions every second. So this should be your speed. It should not be too low or too high, because again, then it will affect the cardiac output. So when you compress the chest, you have to relieve it also. So the release of the chest compression is very, very important, and that needs to be taken care of. So allow the complete chest recoil between the compressions. But remember, when you say recoil, you should make your hand come into the neutral position, but do not lift your hand, because the identification of the landmark will be lost once you lift it. So that's why you keep your hand there, but always try to allow the complete recoil. Do not stop the chest compressions unnecessarily. If somebody is talking to you, somebody is interrupting, no. You need to continue chest compressions continuously, because unless you provide 5 cycles of 30 chest compressions, that is 150 compressions continuously without stoppage, then only it will be effective. If you stop in between, then the chances of recovery is not good, and it is not considered as an optimal chest compression. Now, why we say this is important? Now, the reason which I mentioned about the speed, the depth, and the complete chest recoil, the reason is very, very clear. So when you compress the chest, the sternum and the vertebra in between lie the heart. So by this compression, you are reducing this space. So by this, there will be a manual compression of the heart, and that will pump blood out of it. And this is what we require. But again, the heart needs to be refilled. That's why you need to completely recoil your hand. Then only the heart will expand, and the venous inflow will come into the heart, so that it will be getting filled up. So this is what needs to be done. We have mentioned a technique. So start providing 30 compressions in one set. And we said that you have to provide at the speed of 120 compressions per minute, and you may not be remember. So what the key is, you need to chant loudly, and you have to speak 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, and so forth till 30. And then again start from 1. So this will allow you just not to count for 30 into 5, that is 150 compressions, but it also maintains the speed of your chest compression. And in case if there are more than one person, because when you start doing this chest compression, it is a very hectic, energy requiring process. So usually we have seen that after approximately 150 compressions, the person gets tired. So it will be very good if after 5 cycles or 5 sets of chest compression, 30 chest compressions, if other person is available, then you need to interchange with them, so that you can get a relaxation of approximately 1.5 minutes, and then you can come back. But in case if nobody is there, you can continue till you get tired. So you can continue non-stop in that situation. So once you have provided 30 chest compressions 5 times, that is 150 compressions without interruption, at this point you can check for the response again. Sometimes patient may show a response, because by this time the oxygenation levels will start going to the various tissues, including the heart, and probably the heart may have its return of spontaneous circulation. It may start its activity. And if it starts its activity, if the patient brain gets good blood flow, good perfusion, then patient will show some response. So if you see that the patient is moving, if the patient is having any cough or vocalizing, this means the patient has a response. Now, in case if patient is responsive, then you can shift the patient to the nearest medical center, so that they can see what is the underlying etiology, they can correct that etiology, and the patient can be managed further. But in case if the patient is non-responsive, in that situation, you need to continue this chest compression again. So this means if patient remains non-responsive after this, again, provision of 30 compressions 5 times, you need to continue the cycle again and again. There is no time limit for providing the chest compressions. You can continue it for various duration, because you have already activated the emergency medical services. So by the time they come to you, you can continue the chest compressions of this patient and check the response every 5 sets of 30 compressions. So this needs to be continued. Now, sometimes if you are in a remote place and you are concerned at how long to continue CPR, now, since you have already activated the emergency medical services, so by the time they comes, you can hand over the patient to them and they can continue the CPR. In case if the other person, they can take over, as I mentioned, you can interchange with them, so that a good effective CPR can be provided with them. Or in certain situation, patient shows the response after providing the chest compression. So in case, then obviously patient is having signs of life, and that needs to be taken as return of spontaneous circulation, you can stop CPR and continue monitoring the patient. At times, it can happen that if you're in a remote area, there is nobody to help you, the emergency services have not arrived, you're providing the chest compression for long and you become exhausted, you become tired. At that time, you can excuse for not providing further chest compression, because if you continue, it can harm you and you can also get collapse. So that's why if a rescuer is exhausted, you can stop CPR. Also, at certain point of time, as I mentioned earlier, there could be unsafe situation. For example, the earthquake scenario. The earthquake came and you started, somebody has taken the victim to a safe place, but then again, maybe that nearest building is shattering or the earthquake is coming again. So if the scene becomes unsafe, maybe in situations of even floods and all those things, if the scene becomes unsafe, you wait for the help to come to you so that the scene can be made safe for you, and then only you should start CPR so that your life is not danger. So once patient is responsive, that is, patient is moving, coughing, or vocalizing, then you can place the patient in later position. Medically, we say it to be a recovery position. And how to do a recovery position? The steps are very, very simple. I think sometimes we'll demonstrate you when you do a real-time practice of CPR. We'll show you how to do effective chest compression and also how to make the patient in a recovery position or later position. The steps are very simple. What you need to do is the side on which you are lying, you just make the patient bend the arm like in a Tata position. So you can just keep a Tata position. The other arm can be folded like this, if you see in this figure, and the patient's palm should lie just below the patient's chin, right? Thereafter, you fold the opposite side leg by 90 degrees and holding the knees and the elbow, you try to turn the patient towards yourself. Keep the opposite leg folded like this, if you see in this figure, and this hand will remain just below the chin. So in this way, the patient becomes very, very stable. And the advantage of this position is, in case if patient have some vomiting, then the patient will not aspirate. By this position, everything will come out. Also, at times when the patient is unconscious, the airway obstruction can happen. Airway obstruction, I mean, when somebody is lying supine, is unconscious, the tongue can fall back. And when the tongue falls back, it closes the glottic opening, and the patient may not be able to breathe. But if you make the patient in a recovery position, the tongue will be away from the glottis, the airway will remain patent, and then patient can be having an unobstructed airway and patient can breathe. So these are the advantages of lateral position. But by the time the ambulance comes, you need to monitor the patients every 2 minutes, that he's still conscious, he's still having breathing movements, and you keep assessing this patient every 2 minutes till the patient gets some help from the emergency medical services. And once the emergency medical services, that is ambulance, comes to him, you need to transfer this patient to the nearest medical center. Now, there could be a situation where you should not be starting the CPR. Now, one is scene is not safe, I mentioned. The other is the patient becomes responsive after an initial lapse of unconsciousness. The other situation could be where there are signs of irreversible death, like rigor mortis, and you can identify if the patient is stiff, if a patient is dead for a couple of minutes, hours, and in that situation, the rigor mortis can start on. So these are the signs of irreversible death. In those situations, you may not be attempting for the resuscitation to these patients. So having said that, this is a very simple algorithmic approach of compression on the life support to be done by all bystander CPR outside the hospital. As I mentioned earlier, when we start off, when you will reach your internship, you'll be added on something extra to it. That will be the use of certain drugs and the ventilation part also. So that will be a subsequent step. We'll discuss it in subsequent webinar, wherein you can learn that what type of ventilatory strategies are required for these patients, what are the drug options which are required for these patients, and when these patients reach the hospital, what type of assessment is required, what type of blood sampling is required, and how to look for the abnormalities in them and to correct them. So these are all part of the advanced life support, which is called as comprehensive cardiopulmonary life support that needs to be learned for in-house management of the patient with a cardiac arrest victim. So at this point, I think we can take the question answers. If any questions are there, we can always discuss and take them further on.
Yes, sir. Thank you. Thank you so much for an enlightening session, sir. I'm sure everyone is benefit by this. And this was a much needed realization. We have a couple of questions, sir. Whenever you're ready, sir.
Yeah, I'm ready, madam.
Okay, sir. So one of them asked, is CPR effective in case of hanging and strangulation? And if it's performed immediately?
Absolutely. I said because the oxygen reserves in the body is only for say 5 minutes or so. So even any victim, whether it is poisoning, whether it is hanging, whether it is strangulation, whether it is drowning, whether it is toxicity, whether it is trauma, the CPR should be attempted in all situations. Now, as I mentioned earlier, the etiology may be different. When we say the etiology of hanging, the etiology is primarily the hypoxic events there. So probably the ventilatory managements are also required for those patients who have cardiac arrest after the hanging event, and they need to be appropriately ventilated because there is a deficiency of oxygen, and that requires expertise. But outside the hospital, there may not be ventilatory management. So if you start the chest compressions, you can buy some time so that by the time patient reaches hospital, at least something can be done to make him survive. That's why whatever the etiology of the cardiac arrest, CPR needs to be attempted and then shift the patient to medical services so that definitive care can be provided to these patients.
Okay. Thank you, sir. Sir, there is one more question. Should we stop the compression if the victim gasps?
Right. So this is a very, very important question whosoever has asked. Now, gasping is not a normal breathing. Now, when you see a patient, the normal breathing is patient inspires and then expires. But in case if there is any underlying event, any cardiac etiology, or maybe a neurological injuries, these patients, they may not have appropriate breathing efforts. And these are called gasping. So gasping is not good ventilatory phenomena. Gasping is not a breathing efforts. So gasping should be considered as absence of breathing. So any patient who is gasping, now I think in very local language, sometimes those of you who are running marathon, and after a half marathon or a full marathon, you say, I'm gasping. That gasping or agonal breathing are different. If you are having increased respiratory rate, that's a normal. But if they are something like a sigh, if patient is trying to breathe in, or there will be a very jerky breathing, those are called agonal breaths. So these type of agonal breaths are abnormal breaths, and they should be termed as cardiac arrest only, and the chest compression should be provided. Until unless you see a definitive respiratory breathing efforts, then only you need to stop the chest compression.
Okay. Okay. So one of the common questions that was asked was that how to administer CPR if we see a patient has suffered from rib fractures or a cervical fracture.
Right. So there are two things. One is cervical vertebra fracture. So this can happen if a patient has a history of fall, or patient is a victim of trauma, especially those who rides the two-wheelers without a proper helmet. They can have a cervical spine fracture or even a head injury. Or in a polytrauma patients, patient can have rib fracture. So when we say a cervical spine fracture, as I mentioned earlier, the patient neck should not be moved on. So when you are talking to the patient, come from the front so that patient can see you, and he will not make any attempt to move the neck to see you. Also, you can always ensure that ask the patient when you are checking for the response that I am Rakesh, I'm going to help you, don't move your neck. Or if you have some extra person, somebody can stabilize the neck. So for the neck trauma, we are not going to do anything outside the hospital. Only thing is prevention of any neck movement that can be done by asking the patient or providing manual inline stabilization and subsequently using a cervical collar. So this will not be further exaggerated. It may require, depending upon the type of cervical spine injury, patient may require surgical intervention. So that will be done by the hospital personnel. In case of a rib fracture, nothing can be done outside. You need to provide chest compression, so you should not be worried. And this is a common question. People will say that if they provide a chest compression, rib fracture can happen. It's okay. Rib fracture can happen, but the rib fractures are manageable. But a cardiac arrested victim, after 10 minutes, is already gone. So you can't do anything. So we can repair the rib fractures. We can, they will be, most of the time, they will be on conservative management. Nothing more needs to be done. At times, they can cause pneumothorax. So I think subsequently, we'll discuss something that what are the underlying etiology of cardiac arrest and how to do their management. So pneumothorax is one of them, especially after trauma patients, wherein the rib fracture can lead to collection of air in the chest cavity, and that can lead to cardiac arrest. We just insert a small needle in the chest and the air comes out. So should not be a big issue. But irrespective of the trauma, irrespective of the fear of rib fracture, we should be continuing the chest compression. Otherwise, the patient is already gone. So I think no options. Continue.
Yes. Sir, there was one more question. On an infant, if you are a lone rescuer, how can I perform the compressions?
So herein, when we say the pediatrics or the pediatric age group, including the infants, if you talk of adult, the most common reason for cardiac arrest is usually the cardiac reason, the heart attack or the myocardial infarction or coronary artery disease. In case of infants, it is more commonly because of the air-related issues. The hypoxic cardiac arrest is more common in pediatrics. So that's a major difference. So that's why today I have not tested the CPR in pediatric age group. Usually, depending upon situation, patient would require not only the chest compression, but the supplementation of oxygen also. And the breathing needs to be provided to this patient. Ventilation needs to be provided to these patients. So now for the number of people, now it all depends. If you are somebody is outside the hospital, if somebody is trained for it, you can have more people outside the hospital. If you are all alone, you have to do it all alone. So it all depends how many people are there. So that's why I think getting these workshops and training more and more people is important, so that if something happens outside the hospital, at least in that locality, in that house, in that mall, in that roadside, at least a couple of people know how to do CPR and they can be helping. Usually, what we do is, if they are trained personals, like in ambulances, one person provides the chest compression and the other person provides the ventilation. When we go inside the hospital, we have more people, maybe 4 to 5 people. So in that situation, one person provides defibrillation, or you must have seen those small boxes in airports, railway stations, malls, which are called AED, automated external defibrillator. So one person provides that. If you're inside the hospital, one person provides the drugs, which you talk of like adrenaline, noradrenaline, or to correct the underlying cause, taking the samples, all those things. So the management of a cardiac arrested victims depend upon the number of people available. If one, continue with one and call for help. By the time you get more help, you can involve them so that more effective chest compressions and the other part of CPR can be done.
Thank you, sir. So one of them has asked that, are there any contraindications for CPR and how do I know them?
There are no contraindications for CPR because patient is already dead. So there are nothing called contraindications. So this is always remember that if somebody has a cardiac arrest, you just start CPR. Or in fact, I can say contraindication to CPR, probably the language would be when not to start CPR. So I've already mentioned in one of the slides, if a patient has a telltale sign of a irreversible death, which is called as rigor mortis. Rigor mortis is identified by the stiffness of the body. So if patient is showing these signs, or a patient is, for example, patient is decapitated, the head is away from the body. So those patients may not survive, right? Or the place where the resuscitation is required is unsafe. For example, somebody is inside a house which is on fire. You do not know, you do not have those fire suits with you. So you should not be going inside the burning house, and then there will be 2 victims rather than 1. So those will be, you can say, places where not to start CPR, or you can say contraindication to CPR. But as such, if the scene is safe, if the patient is has a witness cardiac arrest, start CPR for these patients, even attempt for CPR.
Okay. Okay, sir. Sir, one last question is there. How does the victim get oxygen with chest compression only CPR?
Right. So this is another important question. So why we are not, there are two answers to it. I will explain both of them. One is because we are talking of the layman, and then I'll come to the medical students also. So we have seen a couple of times that giving the oxygen to patient by providing ventilation is an expertise zone. So the layman is not able to learn those things, right? So if you start teaching them the chest compression along with the breathing, they will spend a lot of time on breathing. But as I mentioned earlier, the most common reason for cardiac arrest in an adult victim is the cardiac cause. So the chest compression is always a priority. If you spend a lot of time in breathing, which sometimes can take 1, 2, or 3 or 5 minutes, I said if you take 2 to 3 minutes for ventilation, the patient will have already an injury, because if you give oxygen and the heart is not pumping, it's of no use. So that's why body also have some reserves into the body. So at least patient can survive utilizing those reserved oxygen inside the body, in case if you can provide the cardiac output, if you can provide the manual chest compression. So this is the explanation for it. Now this second aspect is, when you provide a chest compression, you are providing the chest compression. So how do you breathe in? When we breathe in, we take a long inspiration, the chest expand, and then goes back. And the same thing we are doing for the chest compression also. When we are providing chest compression, the lungs also compress a little bit. And when we recoil the chest, the lung expands, and probably some amount of air will breathe in and out with the chest compressions. And since we are doing it at a very high rate, 120 compressions per minute, the total amount of volume may be a little higher. Though it may not be sufficient, but yes, for a couple of minutes, this will be sufficient enough. But when you become trained, when you are doing it inside the hospital, we do provide them bag and mask ventilation or oxygen using the ventilators. So that is also provided to them, so that the oxygenation is also maintained. But for layperson or bystander CPR, since we do not have the equipments available, may not be able to do it. Also, it has been seen that majority of people will not try to do mouth-to-mouth ventilation for these patients. But as a medical student, as a medicos now, you can learn the mouth-to-mouth ventilation so that at least your near and dear ones at the house, if they require, you can provide them resuscitation. So that this is the reason that we are not teaching the ventilation to bystanders, but yes, the learned medicos or the paramedics needs to be aware of the ventilation also.
Okay. We would like to thank you, sir, for your precious time, and also for the enlightening upcoming doctors in this golden technique of CPR. James is truly honored to be associated with you, and I feel all of us can deduce from this workshop that performing CPR promptly may save life of someone you love. I hope this workshop marks the beginning of everyone's journey and to save a loved one from impending death. Thank you so much, sir, for your time. And I'd just like to inform that the post-event form that was given needs a change in the access. So we'll be doing that soon. So please do not spam the chat group. And another link will be sent for the post-event form soon. Thank you. Thank you.
Thank you so much, and my best wishes to GAIMS for doing excellent academic and other activities. And we'll keep interacting on different platforms so that we can share our knowledge from each other, learn from each other, and become better professionals in coming near future. And thank you once again to the whole GAIMS team for this opportunity. Thank you so much.
Thank you so much, sir, for enlightening words. Shubham sir, do you want to address?
So I would like to thank everyone. I would like to thank all our audience who joined us today. They took time from their precious busy schedule. As well as I would like to express my sincere gratitude to our founder director of GAIMS, Dr. Rakesh Garg sir, who took time from his schedule for us to spread the knowledge on CPR. CPR is important and vital step to be done. Like everyone should know about CPR. Like they say, like every citizen is a lifesaver. So by that logic, by that saying, it's also related to Indian Resuscitation Council. There is the director of academics there, and its aim is to promote CPR among the common citizens of India. So, like, I would like to request each and everyone, like whoever has learned from this workshop today, you go and you yourself should teach to your family members. Teach, try to grow a cycle so that one person in turn teaches the other, so that this everyone could learn from and benefit from this. Sir, any last word from you, sir, Rakesh?
Yeah, absolutely. I think you have very nicely summarized the importance of CPR. What I mean to say is, with the when we talk of the ambassadors of teaching CPR, I think this is the right time. GAIMS has taken a good initiative. I personally believe that I think Shubham and his team will take some concrete step for the same. That whenever the MBBS courses starts in the first year when they join, there should be some basic, you can say, introduction to the medical sciences should be there. Because I remember when I joined my MBBS, the neighbors knows that they will, I'm in MBBS doing, and they will expect that I will be knowing everything in the first year, which everybody of us know that is not actually. But I believe that the game should take some initiative on a bigger platform, that in first year itself, certain basic things can be taught to these medical students. Like, for example, CPR, for example, first aid management, for example, giving care for some acute injuries, right? And then obviously, they should be made aware of some of the research aspect. How can they see the research, do the research from the first year itself, so that they can understand what is going in the various literature. This should be provided from the first semester of the first year itself, so that they becomes more mature, they can understand better, and they can contribute better to the community. And this will obviously be helping in their medical career. So if something can be done, I think we'll be very happy. And second thing is, the medical students are always very, very enthusiastic. I can see they are very enthusiastic for doing various community services also. So as I mentioned earlier, we have, say, so many medical students entering every year. If a medical student can teach every year, say 50 people around their society, around their home, in the various campuses, I think in coming couple of years, we'll be able to achieve a big target of creating one lifesaver in each family. So that responsibility lies with us. And because at some point, we'll be getting older, we'll be getting elderlies and aged one, and there should be someone around us who can do CPR in case if something goes wrong. So this team, or this trained CPR person should be there across all community. And I think the medical students are the best person, the best enthusiast person to provide some community services. First, they can learn, and then they can contribute. So this is, you can try introducing at your medical colleges 1 day or 2 day courses on the first month of their joining as MBBS, so that they feel so good that at least they know in the first year. Otherwise, they will be struggling for anatomy, physiology, and biochemistry only, and rather than having any medical expertise. But I think which I taught is even for a bystander layman. So why not to teach these medicos who are cream of the students, who have cleared the exam and entered the medical college. So by teaching them in the first month of joining their MBBS will not only give them a confidence, but when they are doing a dissection, they know that they have been told a mid of sternum, so they can at least peep inside and say what is behind the mid of sternum. So they will have a very good memory. Similarly, when they go to physiology, and when we say that the electrophysiological phenomena is happening like this, at least they can understand that it is the clinical implication of anatomy, physiology, and biochemistry in actual clinical science, so they can relate it much better. And thank you. Over to you, Subham.
Thank you, sir, and thank you everyone for joining. And thank for the whole team of Global Health Education Society of GAIMS, led by Rakesh, deserve a huge round of applause for executing it so flawlessly, along with Kudrat, Nirali, and others. So we are looking forward to hosting you again, sir, and we are looking forward to hosting such sessions, academic sessions. So I would like to request our audience to stay tuned and subscribe to our YouTube channel for getting updates to our regular events and regular academic activities. Thank you.
Thank you, sir.